Welcome to this presentation on gynecological emergencies. Women are uniquely designed to conceive and give birth. However, they are susceptible to problems that do not occur in men, and quite frankly, would probably kill most men.
Hi, in this tutorial we're going to have a look at the anatomy of the female reproductive system. So let me start by drawing the relevant anatomy. And I'm going to draw the uterus cut open in the coronal plane. The uterus is the large, slightly conical organ in the center of this image. And we'll begin by labeling the surrounding features. First of all, at the bottom we have the vagina. This is a fibromuscular tubular organ. Its roles in reproduction include receiving male ejaculate and also to provide passage for a baby from the uterus to the outside world. To each side of the uterus lies the ovaries. These are the female gonads. Their role is to produce eggs for subsequent fertilization and sex hormones, which regulate the release of these eggs into the uterus and regulate the menstrual cycle. Continuous with the uterus are two fallopian tubes. These are the passages by which eggs from the ovaries reach the uterus. And at the end of each fallopian tube are a series of finger-like structures called fimbria. Their job is to catch the egg from the ovaries when it's released. Inside the ovaries are a series of follicles. These are developing eggs and the supporting cells, all in various stages of development. So let's just pause here for a quick rundown on the process of an egg getting from the ovaries to the uterus. This is known as the process of ovulation. Once per menstrual cycle, a mature follicle will break open and release the egg from one of the ovaries. The fimbria catch this egg and it travels down the fallopian tube until it reaches the uterus. So now, let's look at the various parts of the uterus. This space in the middle, where the fetus will grow, is called the uterine cavity. This top part is called the uterine fundus, and the narrow part of the uterus is called the cervix, and it is the section that protrudes into the vagina. It is clinically very important, as it is the site of cervical cancer. And it's the part of the uterus that gets checked in a pap smear. The opening of the cervix is called the os. The thick muscular wall of the uterus is known as the myometrium. This muscular tissue contracts during childbirth in order to expel the baby from the uterine cavity. And lining the walls of the uterine cavity is the endometrium. The endometrium provides a surface for the implantation of the egg, which will be nurtured by the endometrium until the subsequent development of the placenta. The endometrium is also the tissue that gets sloughed off and renewed during menstruation. Finally, there are a number of ligaments attached to the uterus. Here is the ovarian ligament, and here I have shown part of a much larger ligament known as the broad ligament. A third ligament, the round ligament, is not shown here. And that's an overview of the anatomy of the female reproductive system. If you've enjoyed this tutorial, please help us produce more by making a donation at www.handwrittentutorials.com.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today.
The menstrual cycle refers to the regular changes in the activity of the ovaries and the endometrium that make reproduction possible. The endometrium is the layer of tissue lining the inside of the uterus. This lining consists of a functional layer, which is subject to hormonal changes and is shed during menstruation, and a thin basal layer, which feeds the overlying functional layer. The menstrual cycle actually consists of two interconnected and synchronized processes. The ovarian cycle, which centers on the development of the ovarian follicles and ovulation, and the uterine or endometrial cycle, which centers on the way in which the functional endometrium thickens and sheds in response to ovarian activity. Menarche, which refers to the onset of the first menstrual period, usually occurs during early adolescence as part of puberty. Following menarche, the menstrual cycle recurs on a monthly basis, pausing only during pregnancy until a person reaches menopause, when her ovarian function declines and she stops having menstrual periods. The monthly menstrual cycle can vary in duration from 20 to 35 days, with an average of 28 days. Each menstrual cycle begins on the first day of menstruation, and this is usually referred to as day 1 of the cycle. Ovulation, or the release of the oocyte from the ovary, usually occurs 14 days before the first day of menstruation. In other words, 14 days before the next cycle begins. So for an average 28-day menstrual cycle, this means that there are usually 14 days leading up to ovulation, in other words, the pre-ovulatory phase, and 14 days following ovulation, i.e. the post-ovulatory phase. During these two phases, the ovaries and the endometrium each undergo their own set of changes, which are separate but related. For the ovary, the 2 weeks leading up to ovulation is called the ovarian follicular phase, and this corresponds to the menstrual and proliferative phases of the endometrium. Similarly, the 2 weeks following ovulation is referred to as the ovarian luteal phase, which also corresponds to the secretory phase of the endometrium. So let's first focus on the pre-ovulatory period, starting with the ovarian follicular phase. This phase starts on the first day of menstruation and represents weeks 1 and 2 of a 4-week cycle. The whole menstrual cycle is controlled by the hypothalamus and the pituitary gland, which are like the masterminds of reproduction. The hypothalamus is a part of the brain that secretes gonadotropin-releasing hormone, or GnRH, which causes the nearby anterior pituitary gland to release follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. Before puberty, gonadotropin-releasing hormone is released at a steady rate. But once puberty hits, gonadotropin-releasing hormone is released in pulses, sometimes more and sometimes less. The frequency and magnitude of the gonadotropin-releasing hormone pulses determine how much follicle-stimulating hormone and luteinizing hormone will be produced by the pituitary. These pituitary hormones control the maturation of the ovarian follicles, each of which is initially made up of an immature sex cell, or primary oocyte, surrounded by layers of theca and granulosa cells, the hormone-secreting cells of the ovary. Over the course of the follicular phase, these oocyte-containing groups of cells, or follicles, grow and compete for a chance at ovulation. During the first 10 days, theca cells develop receptors and bind luteinizing hormone, and in response, secrete large amounts of the hormone androstenedione, an androgen hormone. Similarly, granulosa cells develop receptors and bind follicle-stimulating hormone, and in response, produce the enzyme aromatase. Aromatase converts androstenedione from the theca cells into 17-beta-estradiol, which is a member of the estrogen family. During days 10 through 14 of this phase, granulosa cells also begin to develop luteinizing hormone receptors, in addition to the follicle-stimulating hormone receptors they already have. As the follicles grow and estrogen is released into the bloodstream, increased estrogen levels act as a negative feedback signal, telling the pituitary to secrete less follicle-stimulating hormone. As a result of decreased follicle-stimulating hormone production, some of the developing follicles in the ovary will stop growing, regress, and die off. The follicle that has the most follicle-stimulating hormone receptors, however, will continue to grow, becoming the dominant follicle that will eventually undergo ovulation. This dominant follicle continues to secrete estrogen, and the rising estrogen levels make the pituitary more responsive to the pulsatile action of gonadotropin-releasing hormone from the hypothalamus. As blood estrogen levels start to steadily climb higher and higher, the estrogen from the dominant follicle now becomes a positive feedback signal. That is, it makes the pituitary secrete a whole lot of follicle-stimulating hormone and luteinizing hormone in response to gonadotropin-releasing hormone. This surge of follicle-stimulating hormone and luteinizing hormone usually happens a day or two before ovulation and is responsible for stimulating the rupture of the ovarian follicle and the release of the oocyte. You can think of it this way. For most of the follicular phase, the pituitary saves its energy. Then when it senses that the dominant follicle is ready for release, the pituitary uses all its energy to secrete enough follicle-stimulating hormone and luteinizing hormone to induce ovulation. While the ovary is busy preparing an egg for ovulation, the uterus, meanwhile, is preparing the endometrium for implantation and maintenance of pregnancy. This process begins with the menstrual phase, which is when the old endometrial lining, or functional layer, from the previous cycle is shed and eliminated through the vagina, producing the bleeding pattern known as the menstrual period. The menstrual phase lasts an average of 5 days, and is followed by the proliferative phase, during which high estrogen levels stimulate thickening of the endometrium, growth of the endometrial glands, and emergence of spiral arteries from the basal layer to feed the functional endometrium. Rising estrogen levels also help change the consistency of the cervical mucus, making it more hospitable to incoming sperm. The combined effects of this spike in estrogen on the uterus and cervix help to optimize the chance of fertilization, which is highest between day 11 and day 15 of an average 28-day cycle. Following ovulation, the remnant of the ovarian follicle becomes the corpus luteum, which is made up of luteinized theca and granulosa cells, meaning that these cells have been exposed to the high luteinizing hormone levels that occurred just before ovulation. Luteinized theca cells keep secreting androstenedione, and the luteinized granulosa cells keep converting it to 17-beta-estradiol, as before. However, luteinized granulosa cells also respond to the low luteinizing hormone concentrations that are present after ovulation by increasing the activity of cholesterol side chain cleavage enzyme, or P450-SCC for short. This enzyme converts more cholesterol to pregnenolone, a progesterone precursor. So luteinized granulosa cells secrete more progesterone than estrogen during the luteal phase. Progesterone acts as a negative feedback signal on the pituitary, decreasing release of follicle-stimulating hormone and luteinizing hormone. At the same time, luteinized granulosa cells begin secreting inhibin, which similarly inhibits the pituitary gland from making follicle-stimulating hormone. Both of these processes result in a decline in estrogen levels, meaning that progesterone becomes the dominant hormone present during this phase of the cycle. Together with a decreased level of estrogen, the rising progesterone level signals that ovulation has occurred and helps make the endometrium receptive to the implantation of a fertilized gamete. Under the influence of progesterone, the uterus enters into the secretory phase of the endometrial cycle. During this time, spiral arteries continue to grow, and the uterine glands begin to secrete more mucus. After day 15 of the cycle, the optimal window for fertilization begins to close. The cervical mucus starts to thicken and becomes less hospitable to the sperm. Over time, the corpus luteum gradually degenerates into the non-functional corpus albicans. The corpus albicans doesn't make hormones, so estrogen and progesterone levels slowly decrease. When progesterone reaches its lowest level, the spiral arteries collapse, and the functional layer of the endometrium prepares to shed through menstruation. This shedding marks the beginning of a new menstrual cycle and another opportunity for fertilization. Alright, so as a quick recap, the menstrual cycle begins on the first day of menstruation. For an average 28-day menstrual cycle, the changes which occur in the ovary during the first 14 days are called the follicular phase. Ovulation usually occurs at day 14 as a result of the estrogen-induced surge in luteinizing hormone. The last 14 days of the cycle are the luteal phase, during which progesterone becomes the dominant hormone. While the length of the follicular phase can vary, the luteal phase almost always precedes the onset of menses by 14 days. The uterus also goes through its own set of changes. During the first 14 days of the cycle, the endometrium goes through the menstrual phase and the proliferative phase. During the last 14 days, it goes through the secretory phase.
Well, you probably want to stop the video for a few moments and get up and get yourself a cup of coffee. I know I do. So, let's just kind of go after this. Okay, let's talk about pathophysiology. So, the causes of gynecological emergencies vary. It can be a range from sexually transmitted diseases all the way to trauma. Pelvic inflammatory disease is an infection of the upper organs of the reproductive system in women. It occurs almost exclusively in sexually active women, and if infection expands to fallopian tubes, it will cause scarring. Now, this scarring will result in decreased ability for the egg to move down the fallopian tube and may cause ectopic pregnancy. Ectopic pregnancy basically is where the fertilized egg is implanted somewhere other than the uterus. So one of the more dangerous places that can embed is in these scarred fallopian tubes. It can also result in, PID can also result in sterility. If an infection extends out to the ovaries, it can lead to the development of life-threatening abscesses, in particularly ovarian cysts that could break and bleed, and that'll cause the internal bleeding. And something we want to certainly keep in mind when we're dealing with patients, female patients with abdominal pain in the pelvic region, with sweating, pale diaphoresis. Most common presenting signs of PID are generally lower abdominal pain, and other signs may include abnormal or foul-smelling vaginal discharge, which they would complain about. That's not certainly an exam thing for us. Increased pain with intercourse, fever, general malaise, nausea, and perhaps vomiting. Let's go ahead and take a look at a short video on the sexually transmitted disease chlamydia. This has no narration, so in place of the narration, I'm going to go ahead and play over it Ravel's Bolero. That was delightful. On the subject of delightful, let's talk about bacterial vaginosis. It's the most common vaginal infection and it afflicts women ages 15 to 44. Untreated, it can progress to a premature birth or low birth weight in cases of pregnancy. And it can make the patient more susceptible to other serious infections and cause pelvic inflammatory disease. Let's look at this short tutorial on bacterial vaginosis.
Bacterial vaginosis is a name that can initially sound quite scary. However, it's not as scary when you find out that actually 1 in 3 women will get it in their lifetime. Bacterial vaginosis is different to thrush in that it's a bacterial infection, while thrush is a fungal infection. Bacterial vaginosis, or BV as it's more commonly known, simply happens when there is an imbalance in the normal microflora of the vagina. When this occurs, different reactions happen and can cause us women a lot of stress. Yes, BV is worrying, and you may know it's there because you notice an unpleasant fishy odour and greyish watery discharge. The symptoms can worsen after sex, but BV is not sexually transmitted. However, to reassure you, bacterial vaginosis is the most common vaginal infection in women who are of childbearing age. Again, that's a lot of women, so you are not alone. The symptoms can be easily treated with over-the-counter solutions, such as Canis Balance. Canis Balance provides a triple benefit formula to firstly, relieve the fishy odour and greyish watery discharge associated with BV. Secondly, it hampers the growth of the bad bacteria that causes the odour and discharge. And thirdly, encourages the growth of good bacteria to keep the bad bacteria from overtaking the vaginal flora. All in 7 days. However, you can start to see a difference in just 3. Caniston, get comfortable.
And yes, that was brought to us from our friends at Caniston. Okay, let's move on and talk about some other issues that we see in sexually transmitted diseases. Let's first look at gonorrhea. Gonorrhea grows and multiplies rapidly in warm, moist areas of the reproductive tract. It affects both women and men, and it can be spread by oral, anal, or vaginal sex. Approximately 800,000 people get it each year. Wow. And it may be asymptomatic. Severe infections present with cramping and abdominal pain, nausea, vomiting. You can also have painful urination and bleeding in between periods with women. Gonorrhea is easily treated and cured with antibiotics. Vaginal bleeding. When we talk about vaginal bleeding, there's several causes. Abnormal menstruation, which may be marked and may be disconcerting, especially to young women who are away from home for the first time. I saw this a lot when I was first out of a paramedic school. I was assigned as a paramedic at Eastern Washington University. So we would have issues with young women who couldn't get a hold of their moms for one reason or another to discuss this stuff. So it ended up with us doing a house call on them. Another thing is vaginal trauma. That's injury to the vagina. It can happen during childbirth, but also during sexual assault or accidental occurrences. These injuries normally consist of bruising, but in some cases, severe hemorrhage can be a concern that requires immediate medical attention. Next is ectopic pregnancy. Now, ectopic pregnancy, again, is a pregnancy in which the fertilized egg implants outside the uterus. The fertilized egg can't survive outside the uterus. If left to grow, it may damage nearby organs, and this can cause life-threatening blood loss. And then spontaneous abortion. When we talk about spontaneous abortion, we're talking about miscarriages. The egg has implanted, the child has began to develop in utero, and for one reason or another, the pregnancy is rejected, and the child is then miscarried and passed through, along with the rest of the products of conception. Next is vaginal or cervical polyps, rather. Cervical polyps are small. They're elongated tumors that grow on the cervix. So these are normally identified during exam. A lot of times they're just removed at the time, but they can swell, become irritated, and cause bleeding. And then another cause of vaginal bleeding, of course, is cancer. When we size up an emergency, gynecological emergency, always scene safety. But in our patient assessment, keep in mind we're obtaining an accurate, detailed assessment. That's critical to figure these emergencies out. Scene safety, will you need assistance? If it's a male crew, do we have a female crew member on another team that can come over to help? Considering how many patients do we have, these normally are isolated one patients, the nature of the illness, but have you taken standard precautions? And gynecological emergencies can sometimes involve a large amount of blood. So besides your goggles and gloves, you may want to also consider a gown. If there's an assault suspected, you might want to have police, law enforcement get involved. And the mechanism of injury may be easily understood from the dispatch information, such as a sexual assault. But sometimes when you get on scene, you're going to have to look around and figure out how the person got injured, especially if they're confused or they can't tell you themselves. It's imperative when you're working with these gynecological emergencies that you be very careful about your documentation, especially in the possibility of a sexual assault, which can be called into court sometimes months or years later. In our primary assessment, we want to form a general impression. Is the patient stable or unstable? Sick, not sick? Use the FPU scale, alert, verbal, pain, unresponsive, to determine the patient's level of consciousness. Always evaluate the airway and breathing immediately to ensure that they are adequate. And if they're not adequate, find the way to help the patient breathe better or easier. Palpate a pulse and evaluate skin color, temperature, moisture to identify if the patient is having any blood loss. So, remember, patient that's losing a lot of blood, what is their pulse going to be like? It's going to be rapid. Their skin color, especially when we start considering shock, their skin may be pale. Again, this is where the body is shutting down peripherally, moving blood from the skin and the peripheral areas of the body into the more central areas to support the heart, the brain, the kidneys. Also temperature, perhaps cool, moisture, clammy. These help us determine the amount of blood loss or if they're having blood loss. Most gynecological emergencies are not life-threatening if the patient has signs of shock or weak rapid pulse, pale, cool, or diaphoretic skin. Then we may want to transport rapidly. And don't forget to call for ALS. When we look at history taking, we have to investigate the chief complaint. Some questions are extremely personal, but you have to ask them. Be tactful. Ensure the patient's privacy and dignity are protected. Be sensitive to the patient's feelings. For abdominal pain, ask about onset, duration, quality, radiation, provoking or relieving factors, and associated symptoms such as syncope. Did they feel lightheaded? Did they nearly pass out? Or did they pass out? You might also want to talk about or ask them about nausea, vomiting, and fever. Remember, use your OPQRST when working with abdominal pain. And don't forget to gently palpate during your exam. With vaginal bleeding, we may also want to ask about the onset, the duration, when did it start, has it been steady, ongoing, has it waxed and waned, meaning has it come and gone. You might want to ask about quantity, meaning the number of sanitary pads that were soaked. So if they're using sanitary pads to soak up the blood from the vaginal bleeding, that's a good thing to ask. And then again, the associated symptoms such as syncope and lightheadedness. We also want to ask about this, their sample history. And in the sample history, remember to ask about birth control pills or devices. Keep in mind, sometimes intrauterine devices will give some problems with infection and some bleeding. Ask about their last menstrual period and any sexually transmitted diseases that they may have or may have had in the past. You can also ask about any other medical conditions and their last menstrual period. Your pertinent secondary assessment findings, again, we want to make sure we get the vital signs, blood pressure, pulse, skin color, and if they are slightly lightheaded, perhaps showing signs of early shock, get a set of orthostatic vital signs. Again, orthostatic vital signs are performed initially with the patient either in the sitting or lying down position, moving them then to the sitting or standing position, waiting for 60 to 90 seconds, and then retaking the vital signs. A drop of 20 points in the blood pressure or an increase in 20 beats per minute of the pulse can be indicative of blood loss. Again, we're going to want to look at the abdomen, lay hands on the abdomen, look for distension and tenderness. Rebound tenderness is when we push in, and then when we release, it elicits pain. We're going to look to see if there's visible bleeding. Again, we're just looking. Be very careful not to violate the vulvar area when doing an exam, and we don't do any digital exams in the field. And then look at the patient's neurological or mental status. So with our physical exam, It should be limited and professional. Only examine the genitalia when necessary. Watch for vaginal bleeding. Visualize the bleeding and ask about quality and quantity and the use of external pads to control bleeding. Now, we can use external pads. If we have the sanitary pads on our ambulance, we can certainly use those. Otherwise, you can just use the larger trauma pads. Observe for vaginal discharge. Look for color, consistency, and any obvious foul smell. Syncope, fever, nausea, and vomiting are significant in gynecological emergencies. Make sure you do get a temperature on these patients. Repeat the primary assessment. There are very few interventions with a gynecological emergency. Communicate all relevant information to the staff at the receiving hospital, including the possibility of pregnancy. Maintain the patient's privacy as much as possible. If you're in a public place, move the patient to an ambulance. Have a female EMT participate in the patient's care if possible. Excessive bleeding, we want to make sure that we use the pads and we document the number of pads that we used. The external genitals have a really rich nerve supply, so it makes these injuries in this area very painful. Treat external lacerations, abrasions, or tears with moist, sterile compresses. Under no circumstances should you place dressings inside the vagina. Let's talk about the assessment and management of some of the specific conditions. For pelvic inflammatory disease, a patient with PID will complain of abdominal pain that starts during or after normal menstruation. The pain may be made worse by walking. Patients often present with a distinctive gait that appears as a shuffle. Again, this is a lot of times because of the pain. They're just shuffling. Any enlarged or enlarged gait would cause pain. In this case, pre-hospital treatment is really limited. It's normally a non-emergency transport to the hospital. Let's talk about sexual assault. Unfortunately, sexual assault and rape are common in the United States. EMTs are commonly called on to treat the victim of sexual assault, and we face a lot of complex issues. You may be the first person the victim has contact with after the encounter. Keep in mind, be professional, be tactful, but kindness and sensitivity are extremely important. In fact, that's one of the first things that these victims remember, is how they were treated. Again, these are people who are injured, and we have to show a great amount of compassion and patience. The EMT needs to be aware that drugs may have been used to facilitate a sexual assault or rape. We've heard in the past and in the news quite a bit about these date rape drugs. Be aware that your primary call may be a drug-induced altered level of consciousness. We're going to be seeing the patient for that, and only during history taking and physical exam may we find out that the patient's been sexually assaulted. If possible, give the patient the opportunity of being treated by a female EMT. In the pre-hospital care environment, our focus on the sexual assault patient is the medical treatment of the patient's psychological care, and the preservation of evidence. Now, keep in mind, it may be necessary to persuade the patient not to clean herself. Doing so can destroy evidence. Patients should also be discouraged from urinating, changing clothes, moving their bowels, or rinsing out their mouth. These are areas where evidence will be collected in the emergency department. Take the patient's history and limit any physical exam to a brief survey for life-threatening injuries. Make sure you call the emergency department early with these patients. Explain the situation to the charge nurse, and if law enforcement hasn't been advised, you might want to have them advise law enforcement, even though that is the patient's choice. Ask the charge nurse if a sane nurse is available. Not a sane versus insane nurse, but a sane nurse. Let's talk about sane nurses.
A group of nurses in Syracuse are spreading a message about a free program to help sexual assault victims know they're not alone. The help coming from sexual assault nurse examiners. Well, the service is free, but many victims don't know it exists. News Channel 9's Julia LeBlanc introduces us to the program.
Sexual assault can traumatize a person forever, and they may not know where to turn to for help. That's where SANE nurses come in.
The role of the SANE is really to explain all of the different things that we can offer to the patient. It can be really overwhelming for them, but we go through it really slowly. We do step by step.
There are 4 emergency rooms in Syracuse providing free exams. When victims come to the hospital, both a Vera House advocate and a nurse respond together. Special attention that didn't exist decades ago.
One of the things that we saw before we started the program is patients would come to the emergency department and people were really uncomfortable caring for them. Nurses and physicians didn't receive the appropriate training and they were really uncomfortable. They didn't want to do the wrong thing, so patients would end up leaving without being seen.
The nurse is now providing more than just medical attention.
One of our main jobs as a SANE is not only doing all the technical stuff, but kind of giving that patient that their control back.
Facing the assault with an exam can be scary, but Galloway says it's important to document the trauma even if victims don't plan on bringing the incident to police.
New York State developed new legislation which passed in April of this year that now requires hospitals to maintain the evidence for 20 years.
Another layer of proof and protection, just in case.
We're there to offer them the options. We're there to take care of them. We're there to do what they want us to do with them.
A type of support nurses will continue to give, long after the victim walks out of the hospital. In Syracuse, Julia LeBlanc, News Channel 9.
And those exams are free even if the patient does not have insurance. And just last year, the program in Onondaga County responded to more than 300 cases. A group
So that does it for this particular lecture. There's this table in your book that you might want to review on sexual assault. And we will go over some case reviews, and I look forward to your participation in those. If you have any questions, go ahead and give me a call, and we'll hopefully see you soon.